All right, and then I'm gonna go ahead and take back the screen. And we will go ahead and start talking. I don't know if anyone is on from the towers, but they received their email. They contacted me and Penny right away Monday morning last week. I got down there as fast as I could. And I probably got there about 15 minutes after they started their survey questions. So again, when they first come in, they're gonna take your entrance conference right here, and they're gonna go through it and talk to you about all these questions. So it's really good to become familiar with this entrance conference. I would practice with each other going through the questions and the answers, and pretty much they will start, you know, the food code, how's your housekeeping, laundry, and then they'll move down into your services and how do you do your assessments. And so get to know this form and have it filled out according to your facility. Most of it is filled out in red. That's what me and Penny put in for you. Make sure you take out this completes admission within 5 days of admission. That was not supposed to be on there, so please remove that. And so after we got done with this, they did let us know that this was the surveyor's very first survey. This was a very small community in Rochester. It's actually licensed by itself, so it was just a survey for the Benedict House of, I think they have what, 18 residents. So it took her 3 days to do 2 chart reviews and watch cares, which is a very long time when you're sitting on pins and needles. So I'm going to show you and talk about some of the tags that we got. And they give us this just like they do any other. And then of course we just kind of took notes as we went through, and you know, you try to figure out like what the tag was for, you know, the areas that we talked about. She was very nice. Elmisa did a great job answering questions. She was a little nervous. And so I was just there to kind of help her through. So of course we got one in infection control, hand washing. I can't stress enough about your staff and practicing with them over and over how to properly wash their hands. But it was about when they were doing their medications, they washed their hands, they set up the meds. When they brought the meds, they touched like 1,000 different things, the counter services. She had gloves on, which you don't have to, but she was touching a lot of things. And then she went back and documented with the same gloves on that she gave the pills and touched the surfaces and documented on her tablet, and then removed her gloves. And, you know, so unfortunately, we got a tag for that. And I'm sure it's more nerves. So the more you practice with your staff, the better, of course, because it's nerve-wracking. Posting information. We didn't have the right postings up in the entryway. Just, you know, go back and yes.
I'm seeing that Leslie unmuted. Leslie, are you trying to say something?
No, I wasn't. Sorry.
No, that's all right. Just that the circle kept going around you, which usually means they're trying to talk. So sorry, go ahead.
Okay. So check your postings. We have that in eSource, you know, what your postings should be. Minimum requirements. I was trying to think of what those were.
I think this was the staffing plan. So the report we get from Smart Links, we have to have it manually divided out by building. So we're doing that manually daily now.
So because we didn't have the staffing schedule just for that building, they didn't like that because it was combined with the towers and the memory care. We didn't define out who was at Benedict House. So That's just something to consider. Thank you, Becky, for being on. If you have anything to add, Becky, jump in.
Okay.
Contents of resident records. Trying to think of what that was.
It was the discharge summary was missing required details. It was
Yeah.
the correct form, but it wasn't specific enough what we put in there.
Right, so this was a resident who transferred out of the building, but they didn't really say where she went, did a plan of care go with her? The medications, it just said they were sent, but there was no med record of it. And so you have to really be a little more detailed, especially when they're not an expired med. And I'm gonna look at that and maybe upgrade that a little bit in senior living for us. Emergency relocation, take 1060. We see that a lot. We're not sending that emergency relocation form when we send them out to the hospital.
And the mocks, I'm still seeing that as an issue. So I would say every single person on this call, double verify that that's happening, and not only that it's happening, that you can prove that it's happening. So again, you need to have some sort of copy or duplicate or something. So.
Yep, and our suggestion is to make it a duplicate form so that you have it. I mean, just send it out to Office Max or whatever is closest to get that form duplicated, keep it by your computer where the aides get the CCD printed, and just make that should be something in stand-up. As soon as you hear somebody went to the emergency room, somebody should be checking, hey, did that emergency relocation get sent? Then it should be added to your stand-up or calendar. Day 4, I'm notifying the ombudsman. It just needs to be a better process in your communities. I don't think we've had any community not get that one, so. The next one, the contract information, tag number 0910, that was just the wrong ID number on the contract itself. That was just a mishap with us at the corporate level, not doing the Benedictine house separately, so that we are correcting. And then we get down to the service plan, implementation revisions. We did get a tag because several times that she saw that we changed a service plan, we did not get the signature with the approval of the change. So remember, it doesn't matter if the service plan changes points or levels. If you add a service or delete a service, that is a signature that they are in agreement with that service change. So we have to make sure that we are always getting signatures with a change. We don't have to have a signature if there is no change, but if there is, then you need a signature. And it's not about billing.
And Linda, under that one, I also had, and I don't know if it goes under this or a different one, but missing therapy orders for 2 out of 2 records. And then we were missing.
Yeah, I don't know if she put that, I was just gonna put in 1730. I think she's gonna add that in because I don't think it belongs there. I think it belongs under the treatment therapy management plan, but we'll see when they send our final out. If it's there or not. So I'm gonna talk more about that when I get down to 1730, but thanks. Yeah, I won't skip that for sure.
And I do just want to say over again what you just said, because I continue to get people saying, oh no, if the level doesn't change, I don't need to get a new signature. So I know Linda just said it, but I want to clarify because people get confused on this. If the service changes, you must get a new signature. So that could be going from 16 points to 17 points. It could be something small. If anything changes, they have to re-sign it regardless of whether it changes the level. And needs to go to the business office and needs uploaded as an addendum to the lease even if it doesn't change what we charge for them. And I know you just said that, Linda, but I think people continue to hear it a little bit confusing. So I thought it might be worth repeating.
No, perfect. We don't want you to get tags for these things when we can easily avoid them. And then I'll go down into the individual med management plan and we'll do orientation in a second, but the med management plan and the treatment therapy management plan, I'm going to talk about this again. I'm going to actually switch to something else. So when we look at our policy for our treatment and rehab therapy management plan, also with the med management plan, we are stating that we have individualized the management, whether it's meds or treatments, and that we will put this into our service plan. The policy states that a statement of the type of services will be provided. We document the specific instructions. We identify the treatment or therapy task. Who's going to do the task? How do we notify a nurse if it doesn't happen? And then any specifics related to documentation, complications, adverse reactions. You know, regardless if it's meds, treatments, or therapies, it's all the same thing. So what I want to show you is a couple of things because I think it's really important. And I think when we're doing our service plans, sometimes we're a little fast. We're not really, we're not really thinking about certain questions in our evaluation. We're kind of going through this too fast. And if you're doing a really good job and you're going through that checklist, when you're doing these resident assessments, you are going to note that it should take you at least an hour to do a reassessment on a resident. Part of the regulations, and our question covers this, is number 20, review of all PT, OT, and speech therapy, any evals since last assessment. If we have a resident that is receiving PT, OT orders, we should note it on our evaluation. We also need to say what they're getting. So PT, OT, 2 times a week. I can't type today. For strengthening. Maybe OT for dressing. Maybe speech therapy for eating skills. And it should be a good summary of what they're receiving for our outside therapy. In regards to that, we have some problems with therapies not telling us what they're doing, but it's no excuse not to coordinate that care. So I'm working with therapy right now. If we are using Benedictine therapy, they will be dropping off a communication form with their visits and any notes and concerns. The nurse will be reviewing that, making note of anything that's needed. And then they can go ahead and make sure that is in our service plans, and then upload it into our area. But you'll see here, now it's considered coordinated with OTPT, and that covers that regulation that we are covering that. You can also have it in your order. So if it's like a dressing change or something, that is a treatment. So that would be in our orders with very detailed instructions how to complete that treatment. And if an aide is doing that, an unlicensed staff, then it needs to say if increased redness occurs or if you notice green drainage, call the RN, whatever it is. You have to have that stipulation if things aren't going well, that they need to update us as the RNs. There is plenty of areas to put delegated tasks in our assessments. And if you look and something changed and you don't want to reopen the evaluation, you can certainly always go into just the service plan. And you could open a new service plan and you can do an updated edit. And put it in here somewhere so that you're integrating the therapy and treatment. So if it makes sense in mobility, if they've been falling a lot, I could come in here and update my therapy management plan. And just put in an additional note here. So it is integrated into my service plan. You know, whether it's home care for wound care, whether it's therapies, whether it's home care for the catheter, it needs to be in the service plan. So we may not be doing it, but we have to be able to manage it. We have to know when they visit. We have to know if there's a different outcome. We are in charge of the overall health of our residents. So it does fall back to us. So I just want to pause there and see if there's any questions about the treatment therapy management plan. Quiet group. So of course, if you have something new, reach out. I can help you make sure it gets in there. But that is a big tag. We're seeing a lot of consistencies in our surveys, and I just feel like that's one place we can really start developing and stop seeing those tags in there. I'm going to come back to orientation in a second. Prescriptions, again, annual orders, just not getting them done and uploaded so that we know that the medications are renewed every year. You should have that order on your med sheet so that we don't forget. And also there was a prescription in somebody's apartment that expired in 2019. So now we know that we're probably not doing those medication checks as we should be doing. And that is a quality measure that Benedictine is strongly enforcing that is to be done every week on our residents. We have to look for medication errors. We have to look for expired meds. And I am quite surprised in our communities that we're not reporting medication errors as we should be. And I did have someone tell me a couple weeks ago that we never have medication errors. Well, I find it really hard to believe with unlicensed staff that anyone does not have medication errors. It's just that we're not reporting our medication errors most likely, or we don't understand what a medication error is. So, yep. Kathy
was just saying she had a pharmacy consult, which was very helpful. There is a meeting today where and Linda's included in that, where we're actually talking about our kind of recommendation on pharmacy consult. So that's a really good point, Katie. And there's more to come on that one.
Yes. I'm not aware of any meeting today though, Penny, so I don't think I'm included, but
maybe maybe I'm on the wrong day. Keep going.
Okay. Do you want to talk about the content of orientation and kind of put it in with our mocks? Because I think it's pretty much the same thing, Penny.
Yeah, I mean, so well, there's two different conversations here. So the content of the orientation is that you do need to make sure that we are training the person on the skills. So if they need to learn how to do it, and so their level of license is going to determine whether they learned somewhere, or level of certification is going to determine whether they learned it somewhere else. So an unlicensed, an RA, never worked anywhere, is going to have to be taught by us. A CNA is going to have to be taught medications by us. A TMA is going to have to be taught anything that they weren't already taught on it. But it doesn't negate our need to competency check them and make sure that they are able to do it. And so competency checks from of ADLs can be transferred, but medication management cannot. So it doesn't matter, as long as they are unlicensed, we must competency check on anybody giving meds. And so how we do to make sure that they've got everything that they need, we want to make sure that we have proof of orientation, which is the Educare attestation form that lists all the things required in orientation, that is signed, that you're seeing the RN competency checkoff appropriate to the certification of the person, always to include medications, and that you are seeing the 30-day supervision. So I'm not sure which one you got tagged on for that, but all of those need to be in place. And I know that that is something that even Grape Tree is telling people, oh, we train everybody, or they have that certification. Well, that's true, but that doesn't mean that they haven't been signed off. And medication management is facility specific. Even if they come from inside pool, even if they're switching from Towers to Meadows, whatever the case may be, it is license specific. So that competency needs to be redone. So when you work with pool or you work with other folks, make sure that if they're working nights, can they swing in at 4 o'clock for a couple hours? So you can do that. If they're working the weekends, can they swing in on Friday? Make sure your staffer is aware of it. Make sure Grape Tree is aware of it. You know, it's great. The more training, the better that they come with, that we don't have to do, but it doesn't stop us from being able to have that form that says, I check them off.
Yeah, so for this one, so when you came and did the mock, that's where we found a lot of our issues. And so we've been really intent on fixing those things, and luckily got most everything done the week before survey showed up. So what I think, I mean, we might have some tags on dates because it's obvious to them we played catch up, because everything's dated in this time frame where people longer. But the specific things that I remember that we did not have for agency orientation were not on the agency checklist, and that's the review of the statutes. I couldn't find it in any of the agency education, but it was the review of the statutes, the review of facility policies, procedures, principles of person-centered planning, and service delivery. And those things are covered for our staff as part of our orientation program, but I think it's missing from the agency orientation.
Will you resend me that verbiage? Because I do remember that now, Rebecca, and I wanted to look at our agency checklist and add that in. So,
Okay. Yep.
and I think I started doing a tentative one, but I just want to make sure I don't miss that.
Yeah, I'm adding it to our to-do list, Linda. And I kind of went a little bit off of Madonna's survey to the conversation that we had with Leading Age. And also because I know Grape Tree's messaging of these people coming ready to go has been confusing for people. So did clarify that with Leading Age, wanted to make sure that everybody on this call was clear and had a chance to ask any questions since I sent out that email as well. So any questions on that in general or regarding the tower, or not the towers, Benedict House, sorry.
So TMAs have to be competency tested. Is that correct?
That is correct. So the
Okay,
good news is that people were saying, oh, I'm only asking for TMAs because then I don't have to do the competency. Well, you can ask for CNAs or you can ask for RAs because you're going to have to competency test them anyway. It's the training that we are being freed of. Yes. So, yep.
Yeah.
Everybody needs to be competency tested.
Yeah, I think that's a big misunderstanding. Prescriptions and prescription drugs, just to go back to 1820, prescriptions, they had a lot of PRN meds that didn't have the time frame that they could give them, or a good description of why they would be giving that PRN. It would just say Ativan as needed. Well, you know, can they give it every hour, every 3 hours, and what is it for? So that was something that they had been working on. We just didn't get quite through everybody. And so of course they caught that because she had a lot of time to go through these records. And then services for residents with dementia. Was that the policies, Becky, that we didn't have signed for disclosure?
No, it was, there were prescribed psychotropic medications and the service plan was missing non-pharmacological interventions.
Correct. So again, I want to go back to the service plan. Let me there is a question in here about psychotropics, and I do know when I'm auditing that it's just really skipped over, but it is part of that client assessment every 90 days. And it's about
So while she's looking for that, a lot of you are new, and it was put on hold during COVID, but we have aromatherapy, touch therapy, doll therapy. We have a lot of interventions that are the non-pharmacological interventions. So if you're newer and that's not in place in your community, you can reach out to Dr. Budensiek, who can help you get those in place.
right, and those are so great to try. And I know when me and Penny get contacted about people who fall a lot, that's one thing we're going to ask that you start, because it is a great intervention besides just having medications. So you do need to write here, you know, are they receiving, you know, psychotropics? And you should state like they're on trazodone for sleep or maybe PRN. You should be reviewing those PRNs. Do I need to talk to the doctor about this drug? Because I haven't tried a reduction in a while. Do I note any side effects? But then if you have psychotropic medications, you probably have some type of behaviorals. And so in here, if we have these checked, you really need to do a better job at understanding like what the interventions are. And unfortunately, we didn't have any interventions in in the people that she picked. So it goes hand in hand. It doesn't mean the interventions have to go in that question. They could go anywhere in your service plan where it makes sense. Becky, you took such good notes. I'm looking at my notes. Yours are much better than mine. All in all, it was a great survey. So that was basically it so far until we get the final. And so Becky and Elmisa are already doing the corrections, getting that book put together. And they really did a nice job on the survey. I don't feel like it should have been as long as it should have been. So it was a little more stressful.
And they stayed within the average amount of tags, even though this person was looking for everything. Becky, anything you want to add as far as your experience?
Yeah, so there's 3 food tags that aren't on here. So we got tagged on chicken temp, the backsplash of the grill, cleanliness there, and then using the wrong surface cleaner in the serving kitchens. So those aren't on here. And then also, so the physical plant survey, I think I think we got really lucky. I think they could have tagged us on some things. In fact, you know, there was one thing that he could have tagged and he said, just get it out of here. You'll be fine. So I feel like we got very lucky, but that's not the norm. But one thing that I noticed is really that assisted living focused emergency preparedness plan, we can't go off of our SNF plan. You know, as a campus, and I think this will be, at least for us as a campus, we really need to relook at our EP and make sure that it includes the elements for both SNF and AL. Because that's something that I mean, the tools and resources really saved us last minute, I think, that are on eSource, because I realized as I'm prepping for this interview about Appendix Z and all that, you know, the manuals we have for the SNF and, you know, it doesn't meet the criteria. So like, we're a campus, we use the one book, we have to work together to integrate it as a campus.
You know, that's a really good point, Becky, because I was at, it also happens to be a Madonna community, but I was doing the mock and I asked the EVS person, you know, can you show me your drills and stuff? And he pulled out the community plan. It was all proud. I know the policy and it's right here and I'm following the policy. And I said, unfortunately, that's the SNF policy. It doesn't apply to the AL, even though it was titled as a everybody's policy. So even when you try to say, I'm going to make one thing fit all, and I'm going to put these exceptions here, it's almost impossible to catch every single one of those types of things. And it also mentioned the meadows throughout, as I'm sure that it mentioned Benedict House and it mentioned the towers. But when I said to the new leader at the meadows, if it's 4 o'clock in the morning and you're the only one here, when you look at this, will you know what to do? And the answer was no. And that's where I see Becky saying it really is just too much on the SNF, and you need to rethink about that. And for all of your emergency plans where I'm seeing a campus plan, I see that opportunity. So look at your plan and say, one, is it correct? And two, does it say I have a generator when I don't? Will I know what to do at 4 o'clock in the morning by reading this plan? And if it's not, then we need to work on that plan, because that's what the surveyors will be looking for. And that's what our residents deserve, right? Anything else you would add on that, Becky? That's a really good catch.
The
No.
fire drills, I think we were lucky because, well, first your maintenance EVS person stated that he said we only need 2 drills a year, which was wrong. And then thank God your surveyor guy, he just looked at year 1 in August and said good enough and walked out. Well, they hadn't done the required fire drills. So we really lucked out on that too, but now those have started, correct? We've had a fire drill.
We haven't had an EVS director, but we have one starting next week,
Yeah.
so we'll get that done.
Yeah.
But again, in fairness to that EVS director, that's what their policy says. So take a look at those emergency plans. They are critical.
And make
But
sure you're
Donna
doing your
worked really
fire
hard.
drills.
I think Linda for going down there. Becky, anything else you want to add?
No, nothing besides, I just really appreciate the resources. This guide that you created helped us so much through the entrance and through everything. So if you use the tools, just use the tools. Like, I recommend that 1,000,000%.
Also, speaking of using the tools, the state did update the entrance conference, so we will be updating that coming up as well. Okay, so I'm going to share my screen again. So we talked about Madonna, we talked about the therapy and treatment management.
Good job, Becky.
Yeah, good job, Madonna. Yes, thank you, thank you, thank you. So I think you covered these top 4, right? Linda?
I can't say anything.
Oh, well, that's not helpful. Okay, I think you covered these top 4, right?
Treatment, not the review of the policy and procedure.
Okay,
Incorporating the service plan. I think we talked about, they also were talking about their wellness, person-centered wellness questionnaire plan a lot. So that might come under like one of the other tags with resident care. So just the first 2. And the 4th one.
do you want to talk about reviewing policies and procedures?
Well, we have to renew them annually. You have to show that you did policy and procedures with agency. I don't know if it's on our annual checklist. I think we put it on the supervisory checklist that you can use. annually, which is my highly recommended form to use. Anyone else have any great ideas like how you review your policy and procedures? I know somebody does a group of them on every monthly RA meeting that they go over policy and procedures, so.
And I think it's not necessarily writing them, but reviewing them with staff. And then if in doing that, you find that any of the Benedictine policies need to be updated, just let us know. Otherwise, we try to keep them up to date as well. Okay, so I'm going to go on to Shakopee, and then we can add anything else that anybody thinks. But Linda basically covered a lot of it, but Shakopee, and I don't know if Arliss is on the call, they got a tag in a complaint or concern follow-up relating to wound management. And what happened in a nutshell, there's a lot of detail in it, but in a nutshell, they were assuming that home care was providing the wound care, and home care came out the first time, the person refused and they never came back. And so as Linda was outlining when she was showing you how to kind of see the therapy and the treatment plan where you write, this is what's needed. She used the example of PTOT, but that would also include outside providers. If somebody's getting wounds or they've got whatever, you would want to address that, indicate that an outside person's doing it. If it's something that family's doing, you'd indicate that family's doing it, but you're still responsible to make sure that that is happening and that the care plan is continuing. So that was a pretty significant tag for Windermere Way. They did get fined a significant amount of money for that. So this is an important one. So again, Linda just showed you how to do that using the example of PTOT, but I'm gonna give her the opportunity to add on anything that might be different or additional to cover the Windermere Way situation.
Well, there are questions about wound care and wound care from an outside provider on the evaluation. And someone asked the question, would that include hospice? Yep, we have a question on there about hospice. You have to integrate any outside entity, hospice, home care, wound care. And I think what was primarily missed was just assuming that they came and it went through and not following up. So, and then a week later, a nurse went in and dressed the wounds because they were so bad and didn't think to say, hey, I wonder if wound care is not coming out. So it was unfortunate. It was a level 4 tag, which is our highest tag. And so we're learning a lot about following up, but we're still responsible overall. Even if the wound care nurse is doing a poor job, we're responsible for her poor job. So we do need to get to a supervisor or, so you should be getting notes from all your providers, what they're doing,
Yeah.
update.
This is Arliss. As I'm continually investigating on this one, a lot of it also came down to documentation. So again, even putting in there, but that there was the documentation of what got done, what didn't get done, who was called, and so on. So yeah, that was a huge part with it also.
Right, because we have no proof. Just someone saying, well, I called the doctor, but nobody documented they called the doctor, put the call out and they didn't call back. And then
You
there
know, I
wasn't
think
there
an analogy that I
one-
think about is I see all of you working really well with hospice. Hospice does a very particular role, but you guys are constantly writing notes. You're still taking care of that person. You're coordinating that care. You know what's going on with that person. So really any external vendor should be that same level of oversight and relationship and follow-up.
Yeah, because I believe the nurse stated she called a different one, but she didn't document that she did. So it's just a lot of just fell through because of our lack of documentation. So I just can't stress that enough. Document, 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 and then document.
So Linda, on that note, one of the other external vendors, even though they're part of our team, is Therapy. Do you want to go over the Therapy form that is going to be used?
I did show it.
Oh, did you?
Yeah.
Wow, I've been paying attention. I don't know how I missed that. Okay.
You want me to show it again? I can. Let me
Arliss,
see.
do you remember seeing that? Should she show
What
that
was
again?
that?
There it is.
This will be, it's not final, but this will be something that our therapy department will be using and giving to the nurse with every therapy visit. So if you're using Adara, which they have their own communication form, but any Benedictine therapies, they will be using something like this. One of
Okay,
those, I sent it out for a review to a couple of the nurses. And I think they're gonna add, they missed how often they're going to come. And then they're going to have, did they update the family? So I haven't heard back. I know they're gonna add a couple things in here yet, so. Yep. So it's coming. We've been actually working with therapy for a while on this because originally, we wanted therapy to just drop the notes into our documents. But then they would have to drop into all the IL and then it became a HIPAA thing. So we've been working with legal for a while on this. And then it turns out that even if they uploaded it directly to documents, then we're never gonna see it because we're gonna forget and not review it. So we like the handoff better after we kind of looked at the different scenarios because it forces us to review it. And then we can upload it after we know, and maybe there'll be like a nurse signature who reviewed the notes before uploading, so.
so that's just for our therapy. It's not from outside agencies?
Well, you can ask an outside agency to use the form once it's finalized. You can have a blank copy, but it'll be, Benedictine will be using this for their therapy department. Yep.
Okay,
You could always
Okay,
have a
so
blank stack somewhere that you ask them to fill out. You could even put hospice on here or wound care on here, whatever you want.
So Linda, did you have anything else that you wanted to cover on the call today?
One other thing, when you have, any type of report that MDH is coming or you've been reported to MDH, I think we made some assumptions that everything was going to be fine and that, this outside nurse said that they weren't coming back to Windermere Way because she took care of it all. And I think we were a little shocked when we got the letter that we got a level 4. Lesson learned, anyone makes a complaint or they come, we start an investigation, we start the documentation, we have everything very laid out. And you always call me and Penny, and then we will get Ben involved if we feel we need to, but we have to know what's going on to support you. And we don't wait to do the investigation. As soon as we get an inkling, it's document, make a plan of correction if we know we were in the wrong, so that when they do come, potentially they'll see that we found it and we corrected it. It might not be a level 4. So
And
I think it was a good lesson.
and it was a good lesson to Linda and I too, because Arliss did let us know, but again, we made that assumption that it was gonna be fine. Thus, we did not do the investigation. And so that's the lesson that we can help you with by helping to do an investigation regardless of whether we think it's fine or not. So I do want to acknowledge that Arliss did tell us. So, but if everybody else can do as Arliss did and let us know as soon as possible, we can help with some of that investigation and make sure we're ready to go.
Yeah, I think just not making the assumption that somebody took care of it, you know, we would have kept moving forward.
Yep.
But there is investigation tools, and maybe we need to put that into the, you know, a link so that they have them easily.
Yeah, we could put that on eSource.
It's on there, but it's hard to find, so maybe, yeah,
that would be beneficial.
yeah.
So we could put that in the tools for compliance because it's part of being compliant. So as we start to wrap up here, any other lessons that anybody has, any other information that you feel that Minnesota should know? Our new LALD at the Meadows was the one who told us that there's a new entrance conference, so thank you, Byron. And again, it's a two-way street, so anything you guys know, bring forward. We appreciate your time and have a wonderful day and weekend.